I would firstly say two things. One is that sometimes people confuse cancer that has gone to the liver from cancer starting in the liver. So when we're going to talk about liver cancer, we're talking about cancer which has started in the liver, which hasn't gone from somewhere else to the liver, which is quite common. And secondly, that there's two main kinds of liver cancer. One starts in the cells of the liver, which is called hepatocellular carcinoma, and the other starts in the bile ducts in the liver, the little ducts that carry the bile, and that's called cholangiocarcinoma, or cancer of the bile ducts. And they're the two kinds of cancer that can start in the liver, and we treat them in very different ways. Hepatocellular carcinoma is a cancer which is increasing quite rapidly in Australia. It's about the third most common cancer, third or fourth most common cancer worldwide, but in Australia it is increasing. It is a cancer which is associated with cirrhosis of the liver, and cirrhosis of the liver is where the liver gets scarred. And the common reasons that that can occur is if people have hepatitis B or hepatitis C, or if they drink a lot of alcohol in their lives. So that's the hepatocellular carcinoma. The cholangiocarcinomas are increased in cirrhosis of the liver, but generally we don't know what the cause of cholangiocarcinomas is. They're a relatively uncommon cancer. For developing hepatocellular carcinoma, anything that leads to cirrhosis of the liver is a predisposing factor. The common ones are hepatitis B and C and alcohol, but there are some rarer ones, hemochromatosis, which is a disease where you get too much iron deposited in the liver. There are some autoimmune causes and some rarer causes. For cholangiocarcinoma, cirrhosis of the liver can predispose, and there's a couple of autoimmune conditions of the liver, like primary sclerosing cholangitis, that can predispose to cholangiocarcinoma. For all liver cancers, if we can remove them with an operation, that's the number one thing that we'd like to do. And for some people with cirrhosis of the liver and very bad liver function, liver transplant is considered for liver tumours. They have to meet very strict criteria. They have to be quite small, and it tends to be done for hepatocellular carcinomas rather than cholangiocarcinomas. If surgery or transplant isn't possible, for hepatocellular carcinomas, we often do what we call embolization procedures, where we do what we call an angiogram, where we put an intravenous catheter through the groin and up into the arteries of the liver and inject either some chemotherapy or some radioactive material into the artery that supplies the cancer to try to kill the cancer that way. So that's something that we can do repeatedly. If that doesn't work, then we have medical treatments we can use for hepatocellular carcinoma. And these have been changing quite recently. So up until now, the first type of treatment we would use would be a tablet, which is a molecularly targeted tablet called lenvatinib, but you don't need to remember that. But recently there's been data that the newer immunotherapies plus a drug that inhibits blood vessel formation may be superior to tablets. And these are two intravenous agents which are given once every 3 weeks. And I think they will become definitely a standard first-line treatment, along with the tablets for certain people. So that's hepatocellular carcinoma. And I will mention hepatocellular carcinomas don't respond to our normal chemotherapy, so they're a bit different from other cancers. Cholangiocarcinomas, if we can't cut them out, we tend to treat them with chemotherapy, with intravenous chemotherapy. The other treatment for both really, which is being investigated, is radiotherapy. So our radiotherapists now can give very targeted radiotherapy to where the cancer is in the liver. So if there's relatively limited disease, that can be an option for people as well. So hepatocellular carcinoma is a real challenge often, because you're treating two diseases. You're treating cancer on the one hand, but you're treating cirrhosis of the liver on the other hand. And so the hepatologists are a big part of the treatment for hepatocellular carcinoma. And in fact, they probably treat a lot more hepatocellular carcinoma in Australia than oncologists do. So cirrhosis of the liver can reduce the function of the liver. And if we can't get the function of the liver to a reasonable level, we can't treat the hepatocellular carcinoma at all. So that's one of the big challenges of managing hepatocellular carcinoma. The other, of course, is where these cancers are, because by their very nature, they're having an effect on the liver function. And our drugs of all kinds, our chemotherapy agents, are often metabolized in the liver. So it can get to, so people can present at a stage where their liver isn't fit enough to have any treatment. And that can be a major problem. Early diagnosis is very important for both of these diseases. For hepatocellular carcinoma, people with cirrhosis often are under surveillance if they have known cirrhosis, and they are having regular ultrasounds or CT scans or MRIs, and in some cases they're having regular tumour markers. Like you do a PSA to look for prostate cancer, you do an alpha-fetoprotein or an AFP to screen for liver cancer. So a lot of people with cirrhosis are on active surveillance. But it's harder for people who are not cirrhotic to really pick these things up at an early enough stage to cure, because quite often the liver function doesn't deteriorate till there's quite a lot of disease. So like many, many cancers, we need better methods of early detection of liver tumours. I think all of them, really. I would say that in the recent couple of decades, hepatocellular carcinoma trials have really been ramped up. And after a long period of having very, very few agents, in fact, maybe one or two agents to treat inoperable hepatocellular carcinoma, we now have a number of options and a lot of trials going on in the area, particularly looking at immunotherapies and combinations of immunotherapies with other targeted agents. So I would say that's been a really positive sign recently. And being a common cancer worldwide, it is possible to do these trials. The other area needing research is adjuvant studies after these cancers are resected, looking into the role of immunotherapy and other therapies to improve prognosis and reduce recurrence. Cholangiocarcinomas also have had a bit of an increase in research recently, and a lot of this has been based on our knowledge now that cholangiocarcinomas probably fall into different molecular subtypes. And so we are trying to split these down and look for treatments that work better in certain subtypes of cholangiocarcinoma. And these treatments include targeted agents and immunotherapies. It's quite difficult to do big studies on cholangiocarcinomas because they are not a common cancer. And so these studies really need to be multi-country or worldwide studies to allow recruitment of enough patients to really get a good idea of whether a new treatment is working or not. But there's certainly cancers that could do with a big influx of research. If I was facing a liver cancer diagnosis, I would like to be reassured that my case was being discussed in a multidisciplinary meeting with input from surgeons, medical oncologists, radiation oncologists, interventional radiologists, gastroenterologists. So I would like to know that my situation had been considered from all angles. I would like to know that my surgeon was a specialist in upper gastrointestinal surgery and that my oncologist was too, if possible. And obviously that's not always possible depending on where you are, but that maybe these people were taking advice from a specialist multidisciplinary meeting if they could. And I'd like to know that I had some support. I'd like to tap into any support that my treating doctors could give me, whether that was if I was in a non-curable situation, whether that was palliative care services, so that I knew who to call if I had problems. That they would be the main things. And I'd want to feel that I could ask questions from my treating doctors and that they would ask any questions, they would answer any questions that I had, and feel comfortable asking those questions.